also pulmonary, which is gotten through inhalation of the conidia. And research has shown that it is self-limiting. It can typically resolve itself rapidly, uh, and more so, therefore, leaving the patient with a strong immunity because of that kind of triggering the body to produce antibodies which can be strong against any further infection. Good. So this coccidioidomycosis said that it can resolve itself rapidly, but in some individuals, the disease may progress to what we call a chronic pulmonary condition. And that primary condition where the lungs are become affected, again, this coccidioidomycosis is capable of spreading itself to other parts of the body. Hence, we call it systemic disease. And this could involve the meninges, the bones, joints, and subcutaneous and cutaneous tissues. So you see, from the lungs, this fungal agent can move to the brain, you know, cause the inflammation of the meninges. The bones can be affected, the joints and all that. So it is caused by a fungal agent called Coccidioides mitis. Coccidioides immitis is also a soil inhabiting fungi, just like Histoplasma capsulatum. And studies have shown that this disease is endemic in southwestern of USA, northern Mexico, various centers in South America, and several cases have been diagnosed in also Australia. So this coccidioidomycosis, as we say, is more common in European countries. 60% of individuals suffer what we call benign or transient chest infection that really does not require medical attention. Therefore, it can resolve by itself after an immunocompetent person mounting a good defense mechanism. But about 40% could develop the symptoms. Rather, no, the disease can persist on. So signs like flu-like illness starts after around a month. That's around 7 to 28 days. But averagely within 2 days, one will have started feeling these signs. But within 2 or 3 weeks, again, within 2 weeks, those patients with strong immune system are supposed to have cleared these animals from the body, and therefore healing up naturally. But those who may develop the disease, the main symptoms that can present is like fever, neuritic chest pain, cough, malaise, headache, allergia, night sweats, and loss of appetite. And that's why they say it mimics that signs and symptoms of tuberculosis, which is true because purely these are the clinical symptoms of TB. So this tells you that if, as a clinician, as a medical person, if you're not able to differentiate between now tuberculosis and the coccidioidomycosis, coccidioidomycosis, and then you'll miss it. You, the patient can be treated wrongly for TB for a long time while missing it on the fungal infection. So there must be a very clear communication between the lab person and also the person requesting for the sample test. So around 5 to 10% of the patients after developing these clinical symptoms, these Infection can proceed due to the residues in the lungs and develop what we call pulmonary residual nodules, some sort of swellings and or cavities, perforation of the the glomerulus, you know, and by so doing, making somebody start having what we call, you know, not glomerulus but the alveoli that takes those blood veins running through the lungs with a view of trying to carry the oxygenated blood and the blood to in and out. So once they are affected, because these nodules and cavities, perforation of the lungs is there, becomes difficult. But this can appear several months later. So those around 5%, few of them who may have this disease persist on, it can develop what we call metapulmonary dissemination. I mean, it spreads to other parts of the body. The meninges, the bones, joints are affected. How do we diagnose this coccidioidomycosis caused by coccidioids, immitis? Again, the affected skin, we can do skin scrapings or test in the lab. You can take sputum because of the cough, irritation of the esophagus, the respiratory tract. Take cough or bronchial washings. You can do cerebrospinous fluid, blood, bone marrow, urine tissue. This can also be taken to the lab for testings. Either using, for the lesions, use 10% QOH or Peka ink solution. Okay. As a rule, positive direct microscopy demonstrates severus between 10 to 8 micrometer. We can also do culture. We can do it on to what we call primary isolation media like subroids, dextrose agar, that's SDA, brain heart infusion agar, which will be having some sheep blood. Now, bold statement there gives you some caveat or disclaimer. Interpretation of positive culture from any of the above specimens should be considered significant. Why? Because these are pathological, a serious disease. So even one or two, colonies that can show indication that this is an infection of coccidioidomycosis, it must be taken significantly. Number two, there's a disclaimer or a warning that if we want to proceed and do culture of these coccidioids immitis, this is a very serious biohazard agent. So for protection of the laboratory personnel and the community, do culture handled with extreme caution in an appropriate pathogen handling cabinet. That is the first priority.